Okay, good afternoon, ladies and gentlemen, and thank you very much for inviting me to present to this prestigious meeting. Thank you, Firas. I'll be talking about the surgical options of managing heart failure patient, and I thought we had two actually great talks about really the best options for heart failure patient, which are transplant and assist device. And if you go through the different options, coronary artery bypass graft is a curative treatment for some of those patients, and valve repair and replacement, either mitral valve or aortic valve in some situations. And LV remodeling surgery is an area that might be promising in the future if you have better studies. And external compression devices, which really are a palliative measure. Dynamic myoplasty, cardiomyoplasty, which is one of the procedures that has been abandoned, I think, long time ago now. And VADS and heart transplantation and artificial hearts. And as we all know that the survival from heart failure is really a mean of 50% in 2 years, and cardiac transplantation offers a mean survival of 10 years at least. But as we said, that the surgical management of patients with end-stage refractory heart failure are limited, and heart transplantation remain the ultimate treatment. But unfortunately, because of the donor scarcity and some of the contraindication for the recipient comorbidities remains very limited. And surgical options has been evolving in the last 10 to 15 years, even though there is a lack of large randomized trial in this field, and I think it's because of the ethical issue of how to treat this patient and how to run a proper randomized control trial in those patients. And basically, the surgical approach that I'm going to try to tackle is a coronary artery revascularization in selected patients with ischemic cardiomyopathy and hibernating myocardium. LVADs and ventricular assist device and transplantation. This is already tackled by the previous speakers. And I'm going to talk about mitral valve repair in a concise way, and then I'm going to talk about ventricular reconstruction and restoration. And if we look at the causes of heart failure, ischemic cardiomyopathy really takes the biggest chunk. Almost 2/3 of the patient are related in a way or another to ischemia and coronary disease. So patients with heart failure, really we should evaluate their coronary artery disease, especially that 2/3 of the patient, as we said, are caused by coronary artery. And the coronary artery disease may also play a role in the progression of the heart failure itself through endothelial dysfunction, ischemia, and further infarction in those patients. And basically, the definition of ischemic cardiomyopathy, as we all know, is a patient who has a history of MI or has evidence of viable myocardium or has severe coronary artery disease. And in such a patient, the outcome is really worse than non-ischemic cardiomyopathy. And also, if we look at patient who has a single vessel disease and no history of MI or no history of angina, those patients would have a similar prognosis to patient with non-ischemic MI. And those 2 points are important that I'm just mentioning, because when we look later on into the guidelines, we'll understand the importance of those 2 points. So basically, single vessel disease it has a prognosis like a non-ischemic cardiomyopathy. And basically, to detect coronary artery disease in those patients, it's either through exercise test or imaging or coronary angio. And the development of heart failure post-MI is really related to the size of the infarction and the location of the infarction. and the presence or absence of mitral regurg in those patients, and the inflammatory status of this patient. As we know, heart failure has a big relation with all the inflammatory factor and activating of all inflammatory factor. And it is important in managing those patients to understand that there are two syndromes associated with LV dysfunction that would be amenable for revascularization, which is the stunned myocardium, and it's acute. It happens in acute ischemia, or the hibernating myocardium, which is potentially reversible myocardium, and it's related to chronic ischemia. And if you look at the AHA guidelines in 2013, they would say that patient with chronic heart failure, it is not unreasonable to look at those patients with some sort of imaging to assess the viability of those patients, especially in patients who are known to have coronary artery disease and do not have angina. And basically, in those patients, we have to try to detect first the clinical significant coronary artery disease, and then examine their viability by any of the viability modality available. And the guidelines from 2003 says that coronary artery revascularization for patients with coronary artery disease who have angina or a demonstrable myocardial ischemia is a class 2A indication with a level of evidence of C. So it is a strong indication to look into those patients and to look into the viability of those patients, and that will be helping a lot of them. Also, other societies in North America and Europe has agreed with the new AHA guidelines, and they do recommend to discuss revascularization in those patients, especially patients with left main disease or left main equivalent, or proximal LAD disease, or significant three vessels disease. And if we look at the revascularization and its impact on the ejection fraction and survival, we see that most of the observational studies available show that there is an impact on survival and improvement in the ejection fraction, especially when there is a hibernating myocardium. And that's why when we look at the guidelines, again, they would have it as a class 1 indication if the patient has angina or have in the presence of left main or left main equivalent, and it's a class 2A with a level B evidence if the patient has, again, three vessel disease with hibernating myocardium. Another study which showed significant improvement in survival is a meta-analysis which was published in 2002, and basically it reviewed 24 non-randomized studies, and it shows significant improvement in survival in those patients. And the patient who showed significant survival there was an 80% reduction in the annual mortality of those patients by 3.2 versus 16%, and those patients had a viable myocardium. And in patients who did not have viable or hibernating myocardium, there was really no substantial improvement or significant improvement in survival in that patient population. And then comes one of the largest randomized controlled trial, where they looked at comparing CABG with medical treatment with patient with poor ejection fraction. And basically this trial is one of the largest trials that looked into this issue and did not show any significant improvement in survival, even though in a secondary subgroup analysis they would recommend that most of those patients with ejection fraction of 35% or less who has coronary artery disease amenable for CABG should be treated initially with a course of medical treatment alone, and rather than medical treatment and CABG. And then they continue to say that CABG should be referred to patients who are willing to accept the risk of morbidity related to surgery in exchange for a potential great mortality benefit versus medical treatment. And revascularization should be considered for patients with ongoing angina or ongoing ischemia in those patients. So that was the conclusion of the STITCH trial, and we are going to talk about STITCH trial in the next slide, where we show there are a lot of flaws and bias in the STITCH trial. There is also an improvement in the ejection fraction with revascularization, and this improvement has also been shown in a lot of observational studies, especially in patients who have a viable myocardium. And this was illustrated in 29 studies, where they had a mean ejection fraction improvement of 8% in those patients. And again, the improvement was mainly in the patient who showed a viable myocardium. Another study that shows the timing of improvement in the ejection fraction in those patients, and basically the timing is really different. When the hibernating myocardium in some patients shows improvement in few days, weeks, or even months after restoring blood flow to this hibernating myocardium. And if we look at the improvement in the ejection fraction and the remodeling after revascularization, there is a paper that showed improvement in the systolic and in diastolic diameter of those patients only by revascularization, and also improvement in the sphericity index of the ventricle, which would lead to better efficiency of the ventricular ejection. Again, the improvement in the remodeling was also seen by improvement in the thickness of the myocardium, even in segment of myocardium that were partially thinned out, and that was also possible to predict that area using cardiac MRI imaging. So patient with thinning where the scar is actually less than 50%, those patients would show a long-term improvement and remodeling and improvement in the thickness of the myocardium after revascularization. And basically, this is a picture of MRI showing a patient with a 50% scar that would benefit from revascularization. Again, the study, there is a study also that showed that patient would have improvement in survival even if they don't have improvement in, I'm sorry. Again, the degree of improvement in the ejection fraction is also related to the number of segments that are hibernating in the anterior wall. So if we look at this MRI where the software is showing us that there is a big chunk of the anterior wall not viable, so there are only few segments viable in the anterior wall, this patient would not show us an improvement in the ejection fraction. Again, this is another paper that shows the impact of the left ventricular dilatation on the improvement in the ejection fraction. And basically, in this paper, they concluded that a patient with an end diastolic diameter more than 7 would not have a significant improvement in ejection fraction after revascularization, and would have a higher risk mortality and morbidity from surgery. Another paper, which is also an important paper in this area of revascularizing those patients. So basically now we've seen that those patients are really critical patients that you have to select properly your patient by having good target, as we call, so amenable coronary for revascularization. You should have a viable myocardium. You should not have an extremely dilated ventricle above 7. And all that would help to improve survival and ejection fraction. And those patients would also need to be treated, as said in the guideline. They should be treated first medically to improve the outcome and to have a better outcome. And this is one of the paper where they looked at the effect of beta blocker on those patients before revascularization. And those patients in the Christmas trial showed significant improvement comparing carvedilol and placebo. So patient who received carvedilol showed a better improvement in the ejection fraction compared to patient who received only placebo after surgical revascularization. So they were pre-medicated by carvedilol, then operated on, so they had a better outcome. And this is also another paper here showing that the improvement in the ejection fraction and survival after revascularization was not always related to improvement in the ejection fraction. So there are patients who were operated on. They had 104 patients operated on, and two-thirds basically of those patients showed improvement in ejection fraction, and one-third remained with no significant improvement in the ejection fraction. But the survival free of cardiac death at a mean of 32 months was similar in both groups. And in the discussion of this paper, the author basically conclude that revascularization would protect those patients from further MIs and protect them from cardiac death, even though it does not improve the ejection fraction. This was one of the explanation. And the second thing was that the ejection fraction, as we mentioned in the previous paper, in the hyperkinetic myocardia may improve after days, weeks, or even months. And the ejection fraction in most of those studies was checked yearly post revascularization. And basically, just to highlight this point in the guidelines after this review of the literature in revascularization, so CABG or medical treatment is reasonable to improve morbidity and mortality with patient with severe LV dysfunction, and this is considered a class 2A indication. So basically, revascularization with patient with poor ejection fraction, especially after a good medical treatment, is a reasonable option. It's a class 2A indication with a level of evidence of B. And just to point out this point, that CABG may also be considered in patient with ischemic heart disease with severe LV dysfunction and suitable coronaries, where the whether or not a viable myocardium is present, and this was considered a class 2B, which basically is not clear if there is a good benefit or harm, but it is still an option. And this is what I mentioned at the beginning of this talk, that really there isn't a lot of evidence base. It's basically individualized care for those patients, and sometimes you just have to do what is better for this patient depending on his age and comorbidities and other options available for the patient. We'll jump to the next part, which is my time out? Okay. Okay, well, the next thing is mitral valve repair, and basically I'm going to run through this quickly. That most patients with ischemic cardiomyopathy would have a mitral regurg, and some of the patients with dilated cardiomyopathy would have also mitral regurg. And the mechanism of mitral regurg here is basically, as you all know, is an annular dilatation and papillary muscle displacement due to ischemia. Just to point out that some of those patients do have a mitral regurg only related to the dyssynchrony of the RV and LV, and those patients should be investigated thoroughly to tailor the management for those patients. And basically the pathway for those patients is really to optimize their medical treatment, and then when appropriate, patient would receive a cardiac resynchronization therapy, which may help in a big percentage of those patients. And then if they don't respond, and in selected patient, mitral valve repair would not be a bad option, and would be helpful in adjunction to proper medical treatment and resynchronization therapy. In some of those patients, mitral valve repair would not be a good option, and I'm not going to go through the details why or not. So mitral valve replacement is an alternative, and Antonio Calafiore and Riyadh call it a mitral valve insertion, where you try to preserve the subvalvular apparatus and the chordia and basically just insert a mitral valve inside the native valve. And I like to show this slide every time we talk about surgical ventricular restoration, because I think heart failure surgery is really a parachute for those patients. So saying we should not get hanged to randomized controlled trial. And basically in the guidelines we see that they say that mitral valve, either transcatheter mitral valve repair or surgical mitral valve repair for functional mitral insufficiency is uncertain benefit and should be considered after careful candidate selection. And surgical reverse remodeling or LV aneurysmectomy may be considered again in a carefully selected patient where they have heart failure with a poor ejection fraction. And this is the third surgical option, which is surgical ventricular restoration. And as we all know, that significant dilation of the ventricle occurs almost in 30% post-stenting and in 34% after receiving thrombolytic therapy when they present with an anterior MI. So it is a big problem. And we all know all the stages of remodeling, and basically here, just to cut it short, I think that surgical ventricular remodeling is an option to treat those patients, and would have significant impact at least on their symptoms, if not on survival. Even though there is a big debate about randomized controlled trial and big registries in the past. The door procedure is one of the procedures that has been, again, abandoned because the SVR is the other new modality, and all the compression devices like the core cap device and the surgical myoplasty are all other options for those patients. Thank you very much. I'm sorry for that. That's it.